Regarding hypothermia post-cardiac arrest, I want to put a pro statement. And I started my thinking that way. I thought, if hypothermia would be a device or a stent, I'm sure there would be no debate. Therapeutic hypothermia with conventional cooling methods improves neurological outcome with the number needed to treat of 6 and improves survival with the number needed to treat of 5 in patients successfully resuscitated after cardiac arrest. But there is not really much data. There are only 5 randomized trials with a total of about 500 patients. Most patients do come from the HACA trial. So you could say hypothermia after cardiac arrest has a possible beneficial effect, but the results are still inconclusive and the quality of evidence is low. Let's look at the HACA trial, and the primary endpoint was favorable neurological outcome and secondary endpoint was mortality and complications, and you could see in the hypothermia group favorable neurological outcome was 15% more and mortality was 15% less. But performing cardiopulmonary resuscitation, you may always think, is this my patient who may benefit from that? And who were these patients who were included in the trial? Or is the patient I perform reanimation maybe in the other group who may not benefit from this treatment? So let's look into the HACA trial. They screened about 3,500 people and then they excluded most of them, and only about the 300 were included into the study. So who are these other people actually? And is that really possible? I mean, in neurology, a number needed to treat of 6 is really brilliant. So where are these patients? Do we really always see them? Let's go into the inclusion and exclusion criteria of the HACA trial. So inclusion was witnessed cardiac arrest with ventricular fibrillation or ventricular tachycardia in really young patients with the age of 18 to 75 years. 5 to 15 minutes to resuscitation, which is very quick, and no more than 1 hour to spontaneous circulation. The exclusion criteria are as following. And then there is no real blinded treatment, and the interval between collapse and spontaneous circulation was 20 minutes. That is very quick. There was only a low dose of epinephrine used with about 3 milligrams, and the mean age of the people included were 59 years, so they really be the young ones. What were the side effects of hypothermia in the HACA trial? Mostly about sepsis, bleeding, pneumonia, arrhythmia and pulmonary edema, but all these side effects nowadays can be controlled by modern intensive care medicine. In fact, when I look at these numbers, it may be me when I hold a lecture in the hospital or when I am at work and somebody witnesses my cardiac arrest and starts reanimation as soon as possible with a defibrillation possible rhythm. But it may not be you at home right now. So in Europe we have about 375,000 cardiac arrests per year, and with the inclusion criteria most of them would have been excluded. 30,000 met the inclusion criteria, and from these 30,000 hypothermia could protect 1,200 to 7,000 people. Last words to say, mild hypothermia is the only therapy right now applied in the post-cardiac arrest setting that has been shown to increase survival rates, but only in a small segment of patients. So thanks for your attention.